Welcome to our podcast on the skeletal system. In this system, we are going to begin looking at skeletal development, which will start again with precursor cells. We'll move into cartilage, which is going to be a component in the development of bone. And then in our next chapter, we will move into muscle development. And we, of course, know how intimately tied together our skeletal system and our muscular system really is. We're going to develop the skeletal system from mesodermal precursors. Now, we're also going to have that component that's going to come from neural crest cells. So this is ectodermal in nature. These neural crest cells are going to give rise to the craniofacial structures in the face, whereas mesodermal tissue is going to be used to form the remainder of our skeletal system throughout our body. Now, as we look at where a lot of these precursor cells come from, they're going to come from that paraaxial mesoderm. And if you remember from many chapters ago, the somites are going to be those paired structures on either side of the neural tube that are going to form during development. And these somites we can now subdivide into different components. So as you look at the image, we can see our somites are represented just on either side of our blue neural tube here. The more dorsolateral portion of the somites, these are known as the dermomyotome, and we'll discuss these as we get into muscular development. However, the more ventral and the more medial component is referred to as the sclerotome. Now, this portion, this paraaxial mesodermal portion, is going to give rise to the precursors for our vertebrae as well as the ribs in our body. So as I mentioned before, we're going to have a means of forming bone. We can either do that with intramembranous osteogenesis, which is going to be forming bone from mesenchymal cells, and that's going to be like we see on the flat bones of our skull. But most of our long bones are going to develop through a process known as endochondral ossification, and that's going to first form a cartilaginous template. And so here we start looking at cartilage formation, and that's going to begin about the 5th week of development. Now, osteogenesis, as I've mentioned, is the formation of bone. Chondrogenesis, chondro being the prefix for cartilage, is the formation of cartilaginous tissue. Now, there are 3 distinct stages in which our mesodermal cells will progress through to the point of forming chondrocytes, which is the differentiation state of a cartilage cell. And so first we have this epithelial-mesenchymal transition, and this is going to be to form the mesenchyme from our precursor mesodermal tissue. Then groups of these cells will begin to form cell adhesions with one another and compact themselves closely together, and this is termed condensation. And it's within the center of this condensed mass that we're going to form a chondrification center where chondrogenesis is going to begin. Then as we further move along in our developmental pathway, we move into the differentiation state. And that's where the cells at the center of this condensed mass, which we term chondroblast, because they're beginning to produce cartilage-specific molecules laying down cartilaginous-specific matrix outside the cell. When they completely surround themselves with this cartilaginous matrix, they slow down their cell division, they differentiate. That's when we take this precursor chondroblast and it finally is differentiated into a chondrocyte. Now, many of these mechanisms occur based on transcription factors. They occur based on various cell adhesion molecules, extracellular matrix molecules. And in this illustration, we can see our epithelial-mesenchymal transition, the condensation in yellow, and the differentiation in blue. And we can see through this timeline, we can see the expression of various molecules. Here we have transcription factors that are going to be occurring very early. Bone morphogenetic protein 2, this is a big one throughout development. This is going to be a secreted protein that causes inductive factors to happen and causes cells to change their behavior. We can see these are all expressed very early in this mesoderm to mesenchymal transition. Then as we move into condensation, we have syndecan-3, which is a cell surface receptor. We have these Hox genes, which are transcription factors that are going to be occurring, and we can see those happening. we have this extracellular matrix molecule that begins to be expressed, and we can see overlap. We're still going to have BMPs. Syndicam 1 and 2 is another cell surface adhesion molecule. But then we have these specific NCAM, NCadherin, which we've talked about, the cartilage-specific extracellular matrix proteoglycan, CSPG. This is called aggrecan. And then as we move into our differentiation, that's where these cell adhesion molecules, fibronectin, our extracellular matrix, humongous glycoprotein, carbohydrate, this is hyaluronan. This is simply repeating disaccharide units that can be clustered together as large as a bacteria. And then we have our cartilage-specific collagen that's going to be expressed during this differentiation state. So many of these molecules will be markers for when these events are taking place. Now, this illustration is brand new in edition 9 of your textbook. You may not even have this one yet. But this is showing something very similar, even though the colors are a bit off. The blue are going to be our mesenchymal cells that are going to go through this transition from epithelial to mesenchymal. This is going to be, we can think of this as our condensed chondrocyte, and then we can think of the yellow as our mature differentiated chondrocyte. And we can see many of the factors. We still see our BMPs having an effect, and this is going to directly impact these mesenchymal cells. Here we have various transcription factors, twist, RUNX2. That's going to lead to the expression of fibroblast growth factor, which we see a ton of this in limb development because we have a lot of skeletal elements. Now, FGF is going to have a positive, and that's what the arrowheads mean. It's going to lead to the expression of SOX9 and STAT1. Again, these are inductive molecules. And we can see that SOX9 is going to inhibit this sort of condensation event from happening. SOX9 really is to get this transition to occur, but SOX9 is going to shut this down. The flat bars that you see are inhibitory events. Now we have other transcription factors. The Wnt family, this is a huge family. This Wnt is going to lead to the expression of beta-catenin. And once we start to express beta-catenin, this is going to be a cytoplasmic molecule associated with the cytoskeleton and the cell membrane. This beta-catenin is going to inhibit SOX9, which then allows for the condensation event and then for the progression on to differentiation. Now we also look on this side. We have other factors that are influencing positively the condensation event. So after we form our mesenchymal cells, this chondrocytic condensation is going to be enhanced by another molecule. It's an inductive molecule, plays a tremendous role in development. This is referred to as Indian hedgehog. This is a fairly new one. This is going to cause the condensation event, but it also is going to impact on this parathyroid hormone related peptide. As you can see, this peptide is going to inhibit the progression. So while we're creating our chondrification center, we're going to keep them in the cycle until we build up enough mass, until we have enough beta-catenin that we can then release this on down into our differentiation state. Now, the reason I point out Indian hedgehog is there's a family of these hedgehog-like proteins that play a tremendous role in development. And they're sort of named after animals and characters. Indian hedgehog is not the first, but Indian hedgehog is named after this little guy, this long-eared hedgehog. And there's another family member that is named after the desert hedgehog that we see, the DHH. And we can see this little guy, that's going to play a role in cell-cell signaling. But the first one, and we've actually talked about that when we talked about handedness, is Sonic Hedgehog, and there's Sonic Hedgehog, some graduate student named that one. But we can see that these three related are going to play a role in development, and Indian hedgehog is going to play a very integral role in the condensing of these chondroblasts, and then once we have a sufficient mass of those, we'll turn off some of these signals, turn on other signals, and we'll lead on to the differentiation of the chondrocyte. Now, we talk about chondrogenesis in generic terms, but we have three different types of cartilage. Again, we can get into the specifics of these in histology, and that's going to be happening in the fall semester. But hyaline cartilage, that is our most common type of cartilage. It's found on our articular surfaces of our joints. Fibrocartilage, intervertebral disc, is essentially where we see the fibrocartilage, and elastic cartilage we see in the auricle of the ear or on our nose. That is our elastic cartilage. Similar composition in different places, but we're also going to have some differences. Fibrocartilage is going to look very much like our ligament and tendon type tissue with very little in the way of cells, of chondrocytes. Now, as we mentioned, bone can come from our cartilaginous template, or it can come from de novo development from mesenchymal cells. So osteogenesis can occur in these two ways that we've mentioned before: intramembranous osteogenesis and endochondral bone formation, starting with the cartilaginous template. Our long bones are examples of those. Now again, we get into the specifics of osteogenesis, these two types, in histology. But just to give you a bit of an overview, here we have a histological slide. This is showing some of the connective tissue of the bone. And then the purple is actually going to be bone tissue itself. We can see that our osteocytes are completely surrounded by our bone matrix. We have our bone lining cells, or our osteoblasts, that are depositing new bone at all time. And so that's an example of our bone. Here we have an example of endochondral osteogenesis, where we start with a cartilaginous template. Blood vessels come in, we degrade the cartilage on the inside, and over time we slowly replace it with this lighter colored tissue, that being bone. We're going to do that along the shaft of the bone, this long surface, which is called the diaphysis. And we're also going to do this in the head of these long bones, and this is called the epiphysis. The only place in our long bones where we're still going to maintain cartilage, at least until we're about in our mid-20s, is going to be in the region between the epiphysis and the diaphysis, and this is the epiphyseal plate. We also know this is the growth plate of our bones. Now, we do have situations where we must develop joints between various tissues. And so one type of joint that we can see is a fibrous joint. And we might see these developing, such as the sutures of our skull. And we'll examine those as we get further along in our lecture. But we're going to start out, and we're going to have this loose mesenchyme and then further condensed mesenchyme. And we're going to develop this eventually into cartilaginous tissue or bone. So with our sutures, what we're going to see is this interzonal mesenchyme, this loose mesenchyme between where we're forming the cartilage and the bones. This is going to persist and be changed and converted into fibrous connective tissue. It's going to hold these bones close enough together so that over time this space is going to be filled in, and you will have just a very faint hint of a line between, and that's going to be the sutures of our skull. We can also have cartilaginous joints, and we see these such as the pubic symphysis. We're going to have a fairly similar mechanism for preparing these from our precursor tissues. However, instead of becoming just that fibrous connective tissue that's filled in with bone, in this case our cartilaginous joints, that fibrous tissue is going to be filled in with fibrocartilage, possibly even hyaline cartilage. Fibrocartilage is going to be the typical type that we see filling in. Now, we have this interesting situation that in our elbows and our knees, these are called synovial joints. And again, we're going to have various aspects of this, our interzonal mesenchyme. Some of this is going to persist, and our condensed mesenchyme is going to form the joint capsule. You can see this is continuous with the bone. From bone to bone, we have our articular surfaces on the ends of our bone. But some of this interzonal mesenchyme in the center is going to undergo apoptosis and hollow out into our joint cavity. And this is going to be filled by secretions from cells that line this cavity from the capsule. And this is going to be our synovial fluid, or synovium. This fluid-filled area is going to also help create sort of a shock absorber, because as our bones try to compress down on one another, we certainly have these cartilage surfaces that are going to assist in that to prevent the abrasion. But this fluid, since it can't escape out of the capsule, we almost have like a hydraulic cushion that's going to keep bone separated from bone. So your bones are really floating on water. It's like hydroplaning in your car. But what keeps your bones from sliding off the road, if you will, are our ligaments, anterior cruciate ligaments, your posterior cruciate ligaments, the ligaments of your knee. That holds the knee stabilized while we float on that hydraulic surface. So once again, as we walked through the illustration, we've got the peripheral condensed tissue that's going to be the capsule and those important ligaments that are going to occur. Central mesenchyme undergoes apoptosis, and then we have the synovial membrane lining the capsule, producing that all-important fluid that will be the shock absorber and the cushion for our knees. So now just a little brief review of anatomy, our axial skeleton versus appendicular skeleton. Axial skeleton, we have the skull, the vertebral column, the ribs, the sternum, the remainder of our skeletal system being our pectoral and pelvic girdles and our arms and legs. That's going to be part of the appendicular skeleton. Now, this is an interesting system of development. We have our paired somites. And, it seems to reason that those paired somites would just turn into vertebrae. But again, it's not that easy because what would I ask you on a test? So when we look at the development of our vertebral column, we're going to see that those cells of the somites, specifically those sclerotome cells, we're going to find them, again, around the notochord, surrounding the neural tube. And we're going to get some contribution from body wall mesoderm as well. But when we look at the illustration, we can basically see that the sclerotome cells, the cells of the somites, they're going to be arranged as either loosely packed or densely packed cells within the same somite. So the loosely packed cells are going to be on the cranial side of the somite. The densely packed cells are going to be on the caudal aspect. All right, so let's look at that in the image. Here we have a cross section through our embryo. We've got our sclerotome tissue. Again, this is going to be our ventromedial aspect. Now, if we cut through in this plane, this is going to be sort of a coronal section through. And now we've got our notochord running the full length. Here we have our somitic tissue, our sclerotome tissue. We can see that we've got our loosely packed and our densely packed tissue. And again, this is going to be cranial. This is going to be caudal. We have various arteries. These are called intersegmental arteries. And then we have these myotomes that are going to give rise to muscle. That's going to be important for our next unit. But with our muscle out here peripherally, we're going to have to get nerves out to these muscles. And you can see they're all lining up because we have that dermal myotome portion that's going to give rise to muscle, and it's lined up with the sclerotome. So now let's see what happens. If we can envision this loosely packed sclerotome tissue, this part of this is actually going to move more cranially, and this densely packed sclerotome tissue from the preceding somite, this is going to move downward. So we're going to join portions of this tissue with the tissue immediately behind, and we're going to form our vertebrae right in this neighborhood. We're not going to form the vertebrae just perfectly in line with the muscle and perfectly in line with the sclerotome. We're basically going to split this in half, and part of this tissue is going to become our intervertebral discs. So our intervertebral discs are going to form from this middle tissue. So as we mentioned, some of the densely packed cells that are in the back, they're going to move cranial. Some of the loosely packed cells, they're going to move in the opposite direction. And what we're going to see is the dense cells that remain right in the center part. All right, those dense cells are going to become the centrum, that central body of our vertebrae. Now we can view this a little bit easier when we look at where we began and where we ended. So if we look at our myotomes and our muscles, we know that we are going to create a nerve that is going to come from our neural tube. I know this says notochord, but from the neural tube straight out to the muscle. So we have to split this tissue in half, and some of these densely packed cells are going to remain to become our intervertebral discs. But now if we look along these lines, we're going to see that this loosely packed tissue is, let's see, where are we now? Yeah, this loosely packed tissue here is going to fuse with this densely packed tissue in front of it, and that's going to form our vertebrae right here. And in doing so, we have then created space for that nerve to exit the neural tube and get out to our muscles and our body wall, and the muscles going to our intercostal muscles, to our epaxial, hypaxial muscles. And so that's going to be the splitting that we see between our vertebrae. Now, we talked very early on about notochord. Notochord is going to degenerate. It's not an adult structure. But what we're going to see is as it degenerates, the only remnant we're going to have is in the central portion of our intervertebral discs. And the notochords are going to become this gelatinous center. It's called the nucleus pulposus. Now, surrounding the nucleus pulposus, we have a capsule, a fibrous capsule, which is going to make up our intervertebral disc. And this fibrous capsule is going to be our annulus fibrosus. Now, if that nucleus pulposus, if it is able under pressure to squeeze through some of the fibers of the capsule and protrude out, it potentially is going to impact on a nerve, and that's where we have a bulging or what is referred to as a ruptured or slipped disc. And that's going to be quite painful. Once you damage these, it's very, very difficult to ever regain full comfort and full function. There's just not a lot you can do. So protect your back at all costs. Like, don't bend with your back, bend with your knees if you're lifting something heavy, and protect those intervertebral discs. Now, when we talked about intramembranous versus endochondral osteogenesis, certainly the flat bones of our skull are going to be the ones undergoing the intramembranous type of osteogenesis. But we're going to see that the skull is really going to consist of two, possibly three components. We have the neurocranium, which is really the brain case, and we're going to divide that down even further. Then we have the visceral cranium, which is the skeleton of the face and the jaws. So as we look at these different components of what we know as the head or the skull, we're going to see that it's quite complex in its development. So we'll start with the neurocranium. So with the neurocranium, it's often referred to in development as the cartilaginous neurocranium or the chondrocranium, and you may remember this from comparative anatomy. This is essentially going to form the base of the skull. And when I say the base of the skull, this is going to be the floor upon which the brain will sit. And this portion is going to be part that is formed with endochondral osteogenesis. Now, the membranous neurocranium, we think of this as the calvaria, and this is really what comes to mind when we think of skull, the surrounding brain case that encapsulates the brain itself and covers over the lateral and the top of the brain. This is going to be where we see the flat bones that form through intramembranous ossification and osteogenesis. Now, the important part of the calvaria is we have several bones that are not secured together. This is because these plates of bones are going to slide and deform during the passage of the head through the birth canal. That is absolutely essential. Otherwise, the head's too large to pass. And a lot of times if a fetus or a newborn has been in the birth canal too long, they will come out very much with what looks like a cone head. Their forehead will be very flat and very pointed on top. However, very shortly, in just hours, maybe even overnight, that is going to, because of the pressure of the fluid in the brain, that is going to flatten back out, round out. And it's because those bones are floating. They're not sutured together. They have those fibrous joints. And in some areas, they're quite large gaps between these plates of bones. And we refer to these gaps in the bones as fontanelles. And they will grow up and grow together. And eventually, the whole calvaria will ossify. And you'll just simply see these jagged lines of the sutures between these plates. So here as we look at the cartilaginous neurocranium and the membranous neurocranium, we're not going to get into the viscerocrania and the viscerocrania yet. But here we see through development, we begin to undergo our endochondral ossification. This is looking basically from the caudal portion, the inferior portion up. Here we see the foramen magnum at the base of the skull. This is the floor, again, on which the brain sits. The brain would be sitting just above this as we're viewing it. Now, the membranous neurocranium, we've got the frontal bone, we've got the parietal bone, occipital. That's all going to be a part of our calvaria. And when we look at a newborn skull, here we can see some of the bones. There's the parietal bone, here's the frontal bone, and here you can see the sutures between. They're quite large, these open expanses. We see the occipital bone here. But here we see a sagittal suture. Here we see the coronal suture. And this is the large anterior fontanelle. This is the soft spot in the baby's head. If you ever hear someone talk about the soft spot, that's the one they're talking about. However, there are about 6 or 7 fontanelles. This is simply the anterior fontanelle. Here we have the sphenoid fontanelle. Here we have the mastoid fontanelle. Here we have the posterior fontanelle. But this is the big one. And again, in a couple of, maybe not even a year, possibly with 6 to 8 months, that is going to all grow together and you'll lose that soft spot in the baby's head. The viscera crania, this again is going to be the face, and we have the cartilaginous and the membranous one. The cartilaginous, this is derived from the cartilage of our pharyngeal arches. So we're going to have bones of the middle ear, laryngeal cartilages, the hyoid bone. These are going to be a part of that viscera cranium. Whereas our membranous viscera cranium, this is going to be our mandible, maxillary bone, temporal, zygomatic processes. But we are going to have just a slight portion of endochondral that we sort of include here honorarily speaking. And this is going to occur along the median plane, if you put an E there, of the chin. And so a lot of people that have the clefting of the chin, that's going to be what's left over that's not filled in with that endochondral ossification there at the end. So we have cartilaginous and membranous portions of both the neurocranium and the viscera cranium. And again, this is where you put that together. You can see the base of the brain that sits upon it. That's going to be our cartilaginous neurocranium. There's our membranous neurocranium. Here we can see our membranous viscera crania. And then we have our cartilaginous viscera crania, the cartilage of the thyroid, hyoid bone, and then the bones of the middle ear. Now, not all things work right, especially through development, and we saw that especially with our cardiovascular section. Well, in the skeletal system, that doesn't work quite effectively all the time either. We can have anomalies, and we can see anomalies called rickets. Now, rickets is caused by a vitamin D deficiency. And with a vitamin D deficiency, we're not going to see that we have calcium effectively absorbed into the intestines, and so the bones are not going to be as strong. And when they're not as strong, the pressures of gravity pulling down are going to cause the bones to bow. Now, you're not necessarily going to see this as a congenital defect necessarily. You're going to see this over time as a child gets older. So you'll see this in pediatrics. But that's why when you go to the store and you buy your milk, it's going to be fortified with, that's right, vitamin D. Now, congenital anomaly that you may see, even though it's quite rare, is something that's called a chordoma. Now, this is a malignant tumor. It's a very aggressive tumor, and you're going to see this as we see in this image on the coccyx or in the sacral region. This is going to be remnants of the notochord that have not resorbed. And so this is going to infiltrate the bone, and because it becomes part of the bone, it's very, very difficult to remove all of it altogether. But since it is malignant, it is metastatic, it's going to be hard to eliminate as well. And once it's identified, the 5-year survival is extremely low. So when you talk about 5-year survival, from original diagnosis, how many patients are alive after 5 years, for a chordoma, that number is practically 0. It's very aggressive. Now, a very common type of birth defect that we see is spina bifida, and there are a number of different classifications of spina bifida, but this is where you fail to close part of the vertebral column and or the neural tube. And so you're going to have portions of either opening to the body itself. You might have meninges protruding through this opening on a defect in the back. You may have actually neural tissue protruding through. All of these are classified as spina bifida, where you have an opening into the vertebral column, into the back, into the neural tube itself. So here we see a condition where we have our normal development, normal vertebrae, normal meninges covering our spinal cord. But in this case, we actually have a defect in the back. We have a defect between the vertebrae that has allowed our meninges to protrude through, and now we've got this abnormality on the dorsal surface. This abnormality is skin, meninges, and cerebrospinal fluid. This is called a meningeocele. Here we have an instance where we have a defect in which the spinal cord is protruding through. This is called a myelocele. And oftentimes you will see this protrusion out where you've got the meninges and you've got the neural tissue out here. That is a meningeomyelocele, both of them together. But these are the different categories that we see with spina bifida. It's failure to close that neural tube. Now, one of the most drastic appearances of failure to close the neural system is going to be an anomaly that is referred to as acrania. Now, with acrania, you're also going to see anencephaly in most instances. So we fail to close the rostral neuropore, and therefore we did not develop our membranous neurocranium, the calvaria. And invariably when we do that, we are not going to develop the cerebrum as well. So with acrania, typically we have anencephaly, no brain. And this is a very characteristic look for these newborns that have acrania and anencephaly. They can survive in the womb. They're attached to mom. The brainstem is intact, so breathing, heart rate, regulation of body function is normal, but they have no brain activity, so they do not survive long outside of the womb. Now, less severe, however, is microcephaly. This is where we have a smaller brain and or a smaller than normal calvaria. This is typically occurs when the fontanelles close too soon. And there are various other facial anomalies that we can see, facial stigmata, that will let us know that this is in fact microcephaly. Some of these individuals are perfectly normal, but some do have slowly developmental processes. So that is one thing to occur. If the calvaria is too small, but the brain is normal size, you're going to have unusual pressure. And so in many instances, they will have to go in and fracture the skull to allow that bone to grow more, to give the brain room to expand. And often you'll see that happen, and you will see children wearing these helmets around. That's to protect their brain, to protect their head while those bones are healing from that procedure. Some other anomalies that we can see that are related to the skeletal system, we can have congenital infantile hyperpituitarism. Now, of course, this is where our pituitary is producing too much hormone. In this case, we're talking about growth hormone. And so you're going to grow abnormally fast. And if you have this occurring from birth, if this is a congenital situation, then you're going to have giantism, excessive height, excessive body proportions. However, if this occurs later in life, so it's not a congenital defect, but it's something that occurs later, then you're going to have enlargement and unusual growth of the soft tissues, visceral organs, and just enlargement of the bones of the face, the hands, and the feet. It's not an overall, everything proportionally gets bigger. And here's an example. Here we have a young man standing by his mother. If I'm not mistaken, this young man, and you can see by the door, the top of the door here, he's approaching probably about 7 feet, I guess at this point, 6.5 to 7 feet. I believe he's 12 years old. So that we're talking about giantism. If mom wasn't there, if the door wasn't there, you would hardly be able to tell there's anything wrong because you wouldn't have any frame or reference. So that's giantism, a congenital defect. However, with acromegaly, again, we have the unusually large hands and feet. They refer to this as spade-shaped hands and feet. We have the very long facial features, but we're going to have a lot of other problems too. We can also have cardiomegaly, which is going to lead to hypertension. We can have hypertrophy of sebaceous glands and sweat glands, abnormal glucose tolerance tests. There's a lot of indicators for acromegaly, but the physical characteristics are so distinct, you should be able to pick this up fairly quickly in a physical exam.